Today we'll talk about bariatric surgeries. Bariatric surgeries are the last resort for weight loss. The procedure is reserved for patients who are extremely obese. They have a BMI either at least 40 or higher, or they have BMI 35 or higher with life-threatening comorbidities. Moreover, they have tried other methods but failed. For example, they tried diet and exercise and weight loss pills, but none of those could achieve reasonable weight loss. So now they have to seek this surgery. Based on the nature of each surgery we will talk about, these procedures can be classified as restrictive or restrictive malabsorptive. So restrictive indicate, okay, the procedure will reduce the capacity of one's stomach to hold food. So it will reduce the volume. So restrictive of how much food can be taken in with one meal. Malabsorptive means the procedure works by creating somewhat malabsorption, for lack of a better word. And because unless foods are digested and absorbed into our system, really we are not getting energy. Therefore, by creating restriction, sometimes together with the malabsorption, the individual will have significantly reduced food intake, in this case, energy intake, which would increase the energy deficit required for weight loss. Before we move on, one thing we need to emphasize again is that although these surgeries are the last resort for weight loss, the patients who undergo this surgery do not have a license to go on with an unhealthy lifestyle. They still need to follow dietitian's advice, eat healthy, exercise as necessary, and apply other interventions in their life, even post-operation. Otherwise, weight loss won't be ideal, and some of them may regain certain weight if they don't follow the lifestyle change. So again, surgeries should be considered an adjunct to lifestyle treatment, which should be sustained the rest of their lives. The simplest bariatric surgery is adjustable gastric band. So in this figure, we can see actually what happens is we only apply this adjustable silicone band around the upper corner of the stomach, basically close to where esophagus enters the stomach. So by applying this inflatable band, we could adjust how easily food in this small pouch, which is about 30 milliliter in capacity, can travel down, then eventually go to the small intestine. And this adjustable band is connected with some access port, and this is placed under the skin on the abdomen, and the individual could inject saline through this tube. So when saline is injected, this band is inflated, therefore the restriction is tighter. So food in this small pouch will take longer to enter the next section of the GI tract. And if we need to allow food to go faster, then we'll deflate it. So let a certain saline out, then the band will loosen up a little, then food will travel across. So the reason why this procedure is restrictive is if we look at here, the portion of the stomach above this band is only about 30 milliliters in capacity. Even when we stretch it, allow it to stretch, it can go up to around 90 milliliters. So just FYI, 30 milliliter is equivalent of 1 fluid ounce, or 1/8 of a cup. So with this restriction, obviously after someone eats a volume of about 1/8 of a cup, this portion of the stomach is full. Then it will start sending out signals to the brain to say, okay, stomach is getting distended, so I'm okay. So obviously that will calm down the hunger. So, and as long as the restriction is still here, food takes a long time to travel down, the patient will have a prolonged period of fullness. So that's how this surgery can decrease food intake. So before we move on, we need to emphasize, if we look at the structure of the GI tract depicted in the picture, we really do not cut anything open, nor do we basically bypass any part. So this is the esophagus, so that's where food comes from. And once food will travel to the end of the pyloric sphincter, the sphincter is still here. So it can still control the release of food chyme into the duodenum. This is C-shaped structure. Then, okay, then you have a jejunum and ileum going on. So we're not cutting GI open, we're not removing portion of the GI tract, and we are not bypassing any portion of the GI. So the only thing we do is to restrict the volume available to hold food here. So because of the nature of this procedure, it is less invasive, the least invasive among all the surgeries we will talk about today. The rate for weight loss induced by this procedure is not as fast as, say, other procedures, for example, Roux-en-Y. However, studies indicate, given adequate time, adjustable gastric band can lead to the same level of weight loss as compared to other more invasive procedures, including Roux-en-Y. So this is more slow weight loss, but eventually people can get there if they follow other advice as well. The next type of bariatric surgery is called vertical sleeve gastrectomy. So if we hear anything ending with ectomy, that refers to a surgical procedure during which something is removed, so taken out. So we know gastric acid, so this prefix is for stomach-related feature. So put it together, gastrectomy means, okay, in this procedure, part of the stomach is surgically removed. So let's look at the structure of the GI after surgery. We can see actually small intestine intact, and pyloric sphincter, connection between duodenum and stomach intact, connection between esophagus and stomach intact. What's missing here, actually, if you can imagine, is a bigger portion of the stomach. So why? Because we performed a partial gastrectomy, so this part of the stomach was taken out. So the resulting gastric pouch, or the remaining portion of the stomach, is only about 50 to 150 milliliter in capacity. So obviously this is also restrictive if we think about how much food, volume-wise, can be taken in before patient feels full. So this will also reduce food intake, energy intake will be low. That's the direct way to lose weight over time. Another mechanism for this procedure to induce weight loss is if we look at this section of the stomach that is removed. So this portion is responsible for secreting majority of the ghrelin hormone. And we already learned that ghrelin is the only hormone that makes us feel more hungry. So when we feel more hungry, we will want to eat more. So the higher the ghrelin level, the more we want to eat. However, After the surgery, the portion of the stomach responsible for secreting ghrelin is gone. So the individual won't have much ghrelin. Therefore, the hunger level will be lower. This person will not want to eat as much compared to before surgery. So that's another mechanism for this bariatric surgery to work. Roux-en-Y gastric bypass is the most commonly performed gastric bypass bariatric surgery right now. So it is very effective in inducing weight loss, and actually it is a more complicated surgery, as we will explain. So if we look at what is being done surgically, obviously the stomach is cut into two parts. And so the upper corner, the pouch where stomach joins the esophagus joins the stomach, we see we are connecting a portion of the small intestine here. So that is a artificial connection made. Then here, obviously, we can see here's another surgical incision. So that means we cut open the GI tract, then rerouted certain things. So if we try to make out the original GI anatomy, so let's say we name this part number 1, so the portion starting from the esophagus and the upper corner of the stomach. Then we name this portion number 2, the remaining of the stomach, and duodenum. Then if it goes on here, next part should be jejunum, the middle section of small intestine. Then we have ileum, the distal end of small intestine. So let's say if we name this part number 3, right? So under normal anatomy, so these 3 parts are connect to one after another. So part 1 connects to part 2, then part 2 should go down actually from here, right? Connect with here. So that's intact part 3. However, in Roux-en-Y bypass, what happens is that we cut part 2 and part 3 separately. Then we artificially connected part 3 directly to part 1. Therefore, part 2 is bypassed. So gastric bypass, we bypass the majority of the stomach, including duodenum and the beginning portion of jejunum. Then, of course, we created another artificial connection between part 2 and part 3. So we still want everything connected, but it's just not the original connection. So right now, some of you may think, well, if food comes here from part 1, enter into small gastric pouch, then go directly to, say, jejunum ileum, going down to part 3. Then we can just keep going down to the colon. Okay, then why do we need to keep part 2 in there, actually even create an artificial connection between part 2 and part 3? Well, the reason is that if we think about what is in part 2, this middle section, right, we have a majority of the stomach, which is responsible for secretion of a lot of useful factors. For example, if we recall the absorption of vitamin B12, that requires our proteins and intrinsic factor. And both proteins are secreted by the stomach. Another important reason why we want to keep this section in the middle, part 2, is that, okay, this C shape here is a duodenum. Let's not forget, actually, from here, we have a sphincter of Oddi. So that's where the pancreatic juice and the bile coming from the liver join the small intestine. And we know those are important, critical digestive enzymes and emulsifiers to make digestion and absorption possible. Okay, so if we surgically removed this part, obviously all these essential factors, enzymes, will no longer be available. But by leaving this bypassed section still there and creating this artificial connection here, okay, although it is a delayed gathering, bile and pancreatic enzymes will still join the small intestine, so digestion can still occur. Then what will happen if a digestion will still occur? Well, digestion occurs before absorption, but right now a significant portion of the small intestine is bypassed. Therefore, even with the proper digestion, we have a less surface area in the small intestine available for absorption. So that will create a certain type of a malabsorption. Therefore, Roux-en-Y gastric bypass is considered both restrictive and malabsorptive. So restrictive, same thing here, we have a tiny gastric pouch, and malabsorptive for the reason we just mentioned, right? We do have a significant portion of the small intestine bypassed. So this is again the most commonly performed bariatric surgery right now, and its effect on weight loss is very clear. The most complicated bariatric surgery we talk about today is called biliopancreatic diversion with a duodenal switch. So actually, if we consider the three surgeries we just talked about, this surgery is the combination of two. So first stage of the surgery, we just do a vertical sleeve gastrectomy, so get rid of this portion of the stomach. So why do we do that? Well, usually patients who need this type of surgery, they have a very high BMI. Really, they have life-threatening conditions. But for obese patients, it's very risky for them to go on to receive very complicated surgeries. So that's why for this surgery, it is carried out in two stages. The first stage, we do a vertical sleeve gastrectomy. So that should be able to reduce the body weight a little bit. May not be right at the target, but there will be weight loss. So with that, the second stage of the surgery will become easier. So again, if we do everything with one step, the patient may have life-threatening post-op complications. But if we do it in two steps, the first step will prepare the patient better for the second step. Okay, well, the second step, similar to Roux-en-Y, is we basically cut open the small intestine and reconnect it. Therefore, if we check it here, so bibliopancreatic limb, that's still where we receive the pancreatic juice and the bile. So similar strategy, it just it joins the small intestine at a much lower section. And we can see if we follow the route of food after this reconstructed GI tract, right? So this is where the food flow goes. So all these sections here bypassed. So we can see compared to Roux-en-Y, even a bigger portion of the small intestine is bypassed. So this will create further malabsorption. So this surgery is also restrictive and malabsorptive. Plenty of studies have proved that if we only talk about weight loss, bariatric surgery can have a very impressive weight loss. What's more encouraging is that we know obese patients, they usually have, say, type 2 diabetes, hypertension, and heart disease. A lot of these conditions shortly after the surgery will also improve. So that's why people are saying the benefits over over risk ratio for this surgery is really good if we follow the strict criteria to select the right patients. They can really benefit from it. One more thing about these surgeries, because these individuals come into surgery with a high percentage of body fat, usually during the surgery when their GI tract is reconstructed, the surgeon will also remove a portion of the fat. So, the surgery would involve reconstruction of the GI tract together with, say, removal of adipose tissue. So, even out of the surgery, patient will lose a significant amount of fat. And some people report even 48 hours after surgery, patient's insulin sensitivity improved. So that's very impressive. And what's more interesting is some patients out of the surgery, they just say, okay, before the surgery, when I smell burger and fry, I couldn't control. I just had to eat it. But now, really, I couldn't stand it. I couldn't stand the taste of a beef patty and fries. So, researchers actually named this condition or the phenomenon after surgery, all hyphenated, I don't want the burger anymore syndrome. So something during the surgery changed, and actually the patients will not even taste everything in the same way. So it's really fascinating. So that's the outcome. Very impressive weight loss with improvement in other conditions. However, as we can see, especially the last two type of surgeries, they are very complicated, so invasive procedure. So there are potentials to get post-operative complications. For example, they may have infection, right? The wound, the incision may get infected, and the healing may be delayed, especially considering these patients were obese. And we know adipose tissue doesn't have a lot of a blood vessel in it compared to, say, muscle. Therefore, it is very hard for the fatty tissue to heal after surgery. So that's something we need to consider. And also, the reconstructed GI tract, the, say, stable side, the artificial stoma, may leak. So that'll be ugly. And also, other organs or tissues in the abdomen may be damaged by accident. For example, the spleen, we know that is an organ in charge of destroying mature red blood cells when the red blood cells reach the time to go. And the spleen is behind our stomach. That's why if we do the frontal look, we really don't see the spleen. But it is right next to the stomach, and also pancreas is close by too. So it shouldn't happen, but the surgeons are not God. Mistakes do happen, so sometimes it's just hard to control. And depending on what surgery patients are receiving, they may have dumping syndrome afterwards. For example, if we look at the fourth and the third, especially the third, we can see in this case, food no longer travel through pyloric sphincter. And we know pyloric sphincter controls the release of gastric content bit by bit into the duodenum so that our small intestine can have adequate time to receive everything. But in Roux-en-Y, we can see food just go there directly here, and this pyloric sphincter is bypassed. So therefore, if this person eats a lot of, say, sugary beverage or high-fat food, everything could just go easily into the small intestine, which would pull water into it, then suddenly the patient may feel dizzy, or they may have a kind of, say, diarrhea because of that, may even pass out afterwards. So that's something we need to be aware. So dumping syndrome is common for patients who underwent Roux-en-Y surgery. And how these surgeries work, they either create a low intake by restricting how much the gastric pouch can hold, food that is, or at the same time create a malabsorption. And this actually could increase the risk for nutrient deficiency. These nutrients are of a particular interest in patients post-bariatric surgery because the change in the surgery, they are very likely to be deficient in these nutrients. So if we look at this, vitamin A, vitamin D, so vitamin B12, so all these are connected with fat tissue, right? Fat soluble vitamin and animal tissue for vitamin B12. Therefore, that's something to consider.